Start. My skin is.
Kishore, I cannot hear you. Is it problem on my side or?
Yeah, he's not audible to us also, sir.
Good evening.
Yes, Kishore, please go ahead.
Start now.
No, Kishore, your network is, I think, not.
Are you?
PAVAN and
You have
KISHOR,
kept
if
open
you
in
are in
two.
the same,
Hmm.
PAVAN and KISHOR, if you are in the same room, you may leave meeting from one of the devices and share and present from just one device, both of you.
Sir, I'm audible.
PAVAN, we all are waiting.
Yeah, we all are waiting. I thought I only had network problem.
So, hello, sir.
Yes, please go ahead.
Yes, sir. And then, yeah, in that, in the lumbar plexus, L1 gives rise to iliohypoglossal and ilioinguinal nerves, and then L1 and L2 gives rise to genitofemoral nerves, and then L2, L3, L4 divides into anterior and posterior division. Anterior and posterior division L2, L3, L4, and then all anterior divisions of L2, L3, L4 gives rise to obturator nerve, and then posterior divisions of L2, L3, L4 gives rise to femoral nerve. So, and then these are the branches of the lumbar plexus. So this is an ceramic dissection of a lumbar plexus, and then this anterior view of the abdominal cavity. In that abdominal psoas muscle has been dissected, and we can see lateral cutaneous nerve of thigh, femoral nerve, obturator nerve. This is a needle destination of needle tip in the psoas compartment block. So coming to anatomy, nerve supply of hip joint is if nerve supply of hip joint divided into anterior hip capsule and posterior hip capsule. Anterior hip capsule is innervated by a femoral nerve, obturator nerve, and accessory obturator nerve. Posterior hip capsule is innervated by sacral plexus, that is sciatic nerve, superior and inferior gluteal nerve, nerve to quadratus femoris. These are the dermatomes, myotomes, and osteotomes. So coming to femoral nerve is a motor and sensory nerve. It is derived from the posterior division of ventral rami of L2 to L4 within psoas major muscle, descend into the groove between the psoas and iliacus muscle, and enters the thigh by passing beneath the inguinal ligament lateral to the femoral artery. The femoral nerve lies outside the femoral sheath and is covered by two fascias, that is fascia lata and fascia iliaca. Nerve divides into anterior and posterior branches. The anterior branches are primarily cutaneous, and the deeper branches are motor. So coming to iliohypogastric nerve, the root value is L1. The motor function innervates the internal oblique and transverse abdominis muscle. Sensory functions innervates the skin of posterior, lateral, gluteal, and pubic regions. Coming to ilioinguinal, innervates the internal oblique and transverse abdominal muscle. Sensory function is innervates the skin of superior anteromedial thigh. In males, it supplies the skin over the root of the penis and anterior scrotum. So coming to lateral cutaneous nerve of thigh, it innervates the anterior and lateral thigh down the level of the knee. So coming to obturator nerve, root value is L2, L3, L4. Its sensory motor functions innervates the muscles of medial thigh. The obturator in externus adductor muscles which innervates are adductor longus and adductor brevis, adductor magnus and adductor gracilis. Sensory functions are innervates the skin over the medial thigh. So coming to, I am going to explain about the PNS approaches, and then Pavan will explain about the ultrasound images, sonoanatomy and approaches. Coming to approaches for lumbosacral plexus, there are 4 approaches: venous approaches, cabriolar approaches, venous approach, cabriolar approach, decrease approach, and then Chayin's approach. So first we are going to explain about the venous approach. In venous approach, the patient should be position should be lateral decubitus position, and the needle which will take is 100 mm simplex needle under aseptic precautions. First we will draw the superior border of iliac crest. Superior border of iliac crest, and then we will take a Taffius line, and then midline. We'll draw an imaginary line, the midline. From the midline, 4 cm lateral to the midline, 4 cm lateral to the midline. So one more imaginary line which joining the posterior suprailiac spine. So the point of entry for venous approach is this is a point of incision for venous approach. And then cabriolar approach is medial 1/3, medial 2/3, and lateral 1/3. This is a needle approach for cabriolar approach. So commonly we use this cabriolar approach. Why? Because in venous approach sometimes the transfers are getting lumbar plexus. We can miss the lumbar plexus. So in cabriolar approach, commonly we use this cabriolar approach. Coming to decrease approach, the same decrease approach is proximal to the venous. Needle is directed slightly cephalate to contact the transverse process. Needle is redirected caudally and advanced approximately 1.5 cm further to reach the lumbar plexus, seeking the quadriceps contractions. So once we insert the needle, the end point is the quadriceps contractions will be there. So current we will use 1.5 milliampules of 1.5 milliampules will use, and then once the contraction comes, so we will want to decrease up to 0.3 if the, and then we will give the drug of 0.3 to 0.4 ml per kg of local anesthesia. So coming to Chinese approach, marking as same as the venous approach, L4 spinous process is identified. So needle is inserted is 3 cm caudal and 5 cm lateral. This should elicit a contact with the L5 transverse process. The needle is then re-angled slightly cranial to pass between the L4 and L5. Advancing 1 to 2 cm further from the transverse process, the endpoint will be stitching of quadriceps. So coming to sacral plexus, sacral plexus arises from the spinal nerves of L4 to S4, lies caudal to the lumbar plexus, supplies mostly posterior structures. Sacral plexus is a network of nerve fibers that supplies the skin and muscles of the pelvis and lower limbs. It is located on the surface of the posterior pelvic wall anterior to the piriform muscle. The plexus is formed by the anterior rami of sacral spinal nerves S1 to S4, along with the lower lumbar spinal nerves L4 to L5. The L4 and L5 nerves root joins to form lumbosacral trunk, which descends into pelvis to meet the sacral roots. This is the sacral plexus branches. The sciatic nerve and posterior femoral cutaneous nerve are branches of sacral plexus. So coming to sacral plexus, L4, L5, S1, S2, S3 forms the sciatic nerve. And then branches are coming to branches from dorsal and ventral division. Sciatic nerve is L4, L5, S1, S2, S3 formed by 2 components. The common perennial component arises from the dorsal division of L4, L5, S1, S2, and the tibial component arises from the ventral divisions of L4, L5, S1, S2, S3. Posterior femoral cutaneous nerve formed by dorsal divisions of S1, S2, and ventral divisions of S2 and S3. Branches of dorsal divisions are superior gluteal nerve L4, L5, S1, inferior gluteal nerve L5, S1, S2, nerve to piriformis S1, S2, and then perforating cutaneous nerve S2, S3. And then branches from ventral divisions are nerve to quadratus femoris L4, L5, S1, nerve to obturator internus L5, S1, S2, and pudendal nerve is S2, S3, S4. So sciatic nerve is the biggest nerve in the body. It derives from it fibers from the all roots of the sacral plexus and innervates the entire leg and foot. It leaves the pelvis to the infrapiriform foramen and passes downwards into the middle third between the ischial tuberosity and greater trochanter. The proximal part of the popliteal fossa is further the point at which it divides into 2 terminal branches, the tibial nerve and the for flexor muscles of ankle and the sole of the foot, and the common fibular nerve, also known as common peroneal nerve, for the extensor side of the ankle and dorsum of the foot. So in this, coming to sacral plexus, there are 2 approaches for PNS guided. They are Mansur approach and Labach's technique. So same Mansur approach, the patient will put in the lateral decubitus position and 100 mm pneumoplex needle we will use, and then under aseptic precautions, posterior superior iliac spine and ischial tuberosity we will palpate, and from the in between 6 cm needle incision will be here. So once the needle incision, there will be quadriceps stitching will be there. Hamstring stitching. Once the hamstring stitching is there, we can give local anesthesia, the 0.4 to 0.4 ml per kg. So what technique? The needle is the same. the needle is connected to a nerve stimulator, what I told. It is important to direct the needle medially. Plantar flexion of foot or toes, that is tibial portion, or dorsiflexion or eversion of the foot, that is peroneal division. Contraction of hamstring muscles, biceps femoris or semitendinosus above the knee associated with the motor response most consistent with success. The mean depth at which response is obtained is 7 centimeters. So this is next technique for penis guided is classic approach of labyrinths. Same greater tubercle to posterior superior iliac spine. We want to draw one line, and then from greater tubercle to sacral hiatus one more line. That from in between dissection line, from line 1 to line, from there will be this in between. We will draw line 2. So the needle incision will be between the line 2 and line 2. So under all aseptic precautions, needle incision point as marked as above. 100 to 100 mm stimulus needle will use, and then needle direction will be perpendicular to all planes. The total volume will use 0.4 ml per kg of local anesthesia. Target response will be stimulation of the tibial no component produces plantar flexion and inversion of the foot at 0.3 to 0.5 milliamperes.
Thank you, Kishore. Sangamitra, can we go for next presentation?
Yes, Pavan, can you share your presentation, please?
Yes, ma'am. I will just share my screen.
Okay, okay. Thank you.
Is my screen visible, ma'am?
Yes, it is visible.
Okay, ma'am. As my colleague Dr. Kishore said about the anatomy and the PNS guided approaches, I will now start with the sonoanatomy of lumbosacral. The indication for the lumbosacral plexus block is the anesthesia and analgesia for hips, thigh surgeries, and knee surgeries in the patient that is JD patients or having any condition in which the general
Pavan, your voice is breaking. Pavan.
Yes, sir. Yes, sir.
Your
Am I
voice
audible,
is...
sir?
Yeah, now you are audible.
Okay, sir. So the indication is that the patient who are posted for hip surgery, knee surgeries, or thigh surgeries, which are high risk, that is who is cardiac patient, which is not able to tolerate general anesthesia or a central neurologic blockade, we can use as lumbosacral plexus block for analgesia or anesthesia of the particular surgery. The advantage which we give, which will have, is that the advantage of unilateral effect and the better hemodynamic stability as compared to the central neurological blockade. So this was the one study we have, which are done in our institute by Dr. Harshal sir and Chetan sir and Senthil sir, in which they use lumbosacral plexus block in the high risk patient for hip surgeries. So what are the contraindications? The contraindication will be the bleeding disorders, local anesthesia, allergy, antiplatelet or anticoagulant, patient is on antiplatelet or anticoagulant, the site infection, and patient's refusal. So now the various approaches for the USG guided for lumbar plexus block. First will be the sagittal sonoanatomy. In sagittal sonogram, the transfer process is transfer process of the lumbar vertebra identified, that is L3, L4, L5, by their hyperechoic reflection and their corresponding acoustic shadow, as we can see in the lower down image. As we can see the L3, L4, L5 and their acoustic shadow behind it. And the hyperechoic structure, which is in between the L3, L4, and L5, are the psoas muscle, which can be seen. And in the psoas muscle in the posterior compartment, there is the presence of lumbar plexus, which can be visualized as a hyperechoic structure, and it is most posterior in the location.
The lumbar plexus nerves are also thicker than the muscle fibers. So by identifying in this, we can see there are some hyperechoic structure which can be a lumbar plexus. So the second approach will be the transverse sonoanatomy, paramedian transverse oblique scan. In this, we can see from the image that we are keeping the probe in a transverse and in the trapezius line in the transverse direction, and it is keeping oblique and going caudally, so that we can see the lumbar plexus. In this, there are the muscles which can be seen as the erector spinae muscle, transverse process, psoas muscle, quadratus lumborum muscle, and the anterolateral surface of the vertebral body are visualized. In this, we can see QL muscle, psoas major muscle, erector spinae muscle, and vertebral body and transverse process. The IVC on the right side of the right side and the aorta on the left side can also be visible in very depth. The lower pole of the kidney, which can extend from the L3 vertebral level, is also visualized. It is important to visualize these neuroobject structures during the lumbar paravertebral scan. May be useful as in documenting the epidural spread after an lumbar plexus block. So the third technique is transverse anatomy, that is Shamrock's method, which is the most commonly used nowadays to block the lumbar plexus. In this approach, we can see the curvilinear probe is kept over the flank region, and we can see the three muscles, that is quadratus lumborum, erector spine, and psoas muscle. We call this as a Shamrock method because these three muscles are arranged in a clover pattern, that is psoas muscle anteriorly, erector spinae muscle posteriorly, and quadratus lumborum above, and the transverse process representing as a stem of the leaf. So in transverse sonogram, as we can see in the image, this is the transverse process which represent as a stem of the leaf. And this is the psoas muscle anteriorly above the quadratus lumborum muscle and posteriorly erector spinae muscle, which these three represent as a leaf of the shamrock tree. The anatomical arrangement is the same, representing three leaves. The lumbar nerve root is usually close to the angle between the vertebral body and transverse process, and the lumbar plexus within the posterior aspect of the psoas muscle, typically about 2 cm anterior to the transverse process. These are some troubleshooting during the lumbar plexus block. As we can see, as we know, local twitches of the paraspinal muscle, if we get, that is the direct stimulation of paraspinal muscle. It means that the needle is too shallowly placed, and we should to continue advancing the needle. If needle contacts the bone at 4 to 6 centimeter of depth, no twitches are seen. The needle advancement is stopped by the transverse process. It means we are hitting the transverse process. In that thing, which indicates that the placement of the needle is correct, but we require redirection of the needle. We can withdraw the needle toward up to the skin and then redirect 4 to 5 degrees cranially or caudally. If we get twitching of the hamstring at the level of 6 to 8 centimeter, it means that the stimulation of roots of sciatic plexus, the needle is inserted too caudally. Then we have to again withdraw the needle and redirect it 3 to 5 centimeter cranially. If there is a flexion of thigh at the depth of more than 6 to 8 centimeter, it means the needle is inserted too deep and we miss the lumbar plexus. Further advancement may place the needle intraperitoneally. So we have to stop advancing the needle, withdraw the needle, and reinserting using the protocol outline in the technical in what we technique describe. Then what are the complications which can occur during the lumbar plexus block? The first will be the infection, the hematoma because of the vascular puncture. Then the most common, then the local anesthesia systemic toxicity can happen. Nerve injury, if the needle, we can see the needle properly, the tip of the needle can be seen properly, and hemodynamic instability because of the spread of the drug local anesthesia into the epidural or subarachnoid space. Now, the approaches for sacral plexus block, the PNS guided and the USG guided. PNS guided has already been described by Dr. Kishore. I am going to describe the USG guided approach. In USG guided approach, the most commonly used approach is the parasacral parallel shift. In this, we use curvilinear probe. It is placed on the upper half of the line connecting the posterior superior iliac spine and the ischial tuberosity. In this position, the iliac bone is the line which is seen is the hyperechoic line is seen by the iliac bone, continuous line of the iliac bone. From this position, the probe is shifted infero-medially. Then we can see there is a disruption of the continuous hyperechoic line of the ilium. It means that we are reaching towards the exit of the pelvis, that is greater sciatic notch, where the sacral plexus, we can see the sacral plexus. With slight forward tilt of the probe, the sacral plexus become visible. The needle is inserted from the lateral end of the probe and advance until it reaches the sacral plexus. It is confirmed with the use of peripheral nerve stimulator by getting the twitches of hamstring muscle or dorsiflexion or plantar flexion. Then we can deposit the local anesthetic around 10 to 15 ml of the local anesthetic. Here is the video. First, we will palpate the ischial tuberosity and the posterior superior iliac spine. Then we draw a line which connect the ischial tuberosity and the posterior superior iliac spine. And then we will see what is the midpoint of that line, and we will keep the curvilinear probe 1 centimeter medial to that midpoint, and then we will slowly scan inferomedially until we get the greater sciatic notch, which indicates the exit of the pelvis. And we'll approach the needle from the posterior side. This is the USG video. As we can see, this is one hyperechoic continuous line is of the ilium. Then we will scan inferomedially slowly. We will get the break in the ala of the ilium, and we can see one hyperechoic structure is coming, which is sciatic nerve, or it is sciatic nerve where we are going to deposit the drug. Now the Tahaj approach. Tahaj approach is the second approach in which we are going to block the sacral plexus. As we can see in the video, we will first keep the probe above the anal cleft, and we will guide the probe laterally towards the lateral superior iliac spine. As we go laterally, we will get up around 8 to 7 to 8 centimeters. We will get the greater sciatic notch, and we will get the break in the ala of the ischium, and we can see the sacral plexus. This is the USG guided USG video. As we go up, we will get the hyperechoic line of the ala of the ilium sometimes. And if we get the hyperechoic ala of the sun, then we will shift the probe inferiorly till we get the break in the ala of the ilium, and we will get the hyperechoic structure, which is sacral plexus. Now the third block is the parasacral ischial plane block, which is a facial plane block. It is described by the Dr. Madan Narayan sir in February 2020. The advantage this block gives, it is easy to perform, consistent and easily identifiable bony landmarks are there. No need of neurostimulation. Less likely to have complication as block location is away from the vascular and bowel structures. So how to perform this block? The position will be lateral decubitus, side to be blocked is uppermost. The probe is curvilinear. Probe position medial to the midpoint of the line joining greater trochanter and posterior superior iliac spine. Probe move from the superior lateral to inferior lateral direction, just like the parasacral parallel shift. As we can see in this image, we will going to draw one line from the posterior superior iliac spine to ischial tuberosity, and the midpoint of that line is again marked, and we will going to place the probe medial to the midpoint. And as we move, as we scan downwards, we are going to come into the greater sciatic notch, and we will able to see this image. This is the posterior part. This is the posterior part of the viscera, and this is the sacrum. We are going to come from posterior side of the probe, and we are going to hitting the posterior aspect of the ischium, and we are going to deposit the drug, which will pass slip pass and include the sacral nerve, and block the sacral nerve or sacral plexus, as we can see in this image. So the complication of sacral plexus block will be again infection can occur, hematoma, vascular puncture, local anesthesia systemic toxicity, nerve injury, hemodynamics instability. Thank you, sir. Thank you, ma'am.
Thank you, Pavan, for nice presentation.
Thank you, sir.
So can you stop sharing the slides?
Yes, sir. Yes,
Thank
sir.
you. Yeah, thank you, Pavan.
Thank you.
So basically, these blocks are advanced block, and I understand that being a fellow, you are not very much exposed to these blocks, especially in initial days. But in your institute, I believe Harshal is practicing it regularly. But looking at Pawan's presentation, I was a little bit disappointed because he failed to cover basic point of lumbar plexus. Even if you read, you can uh, understand those points. And when you are presenting something, you have to prepare those things, and you have to prepare it properly. So, Pawan, can you describe the landmark for a PLS guided block, or shall I show it?
Sir,
Sangamitra, can I show it? Can I share the slides? And
Yes, sir, please.
yeah, so I'm sharing my slides. Can you see my slides?
yes, sir.
Yeah. Just a minute. I'll have to stop sharing and stop. Just a minute. Another presentation. Yeah. Yeah. Can you see the slide now?
Yes, sir.
Yeah.
Yes, sir.
Yeah. So when Pawan was talking about anatomy, this is a very important slide for anatomy. I'll show it again. So when we talk about lumbar plexus, basically it is formed by L1, L2, L3, and L4. So when we look at the branches of L1, you can see this is the iliohypogastric nerve and ilioinguinal nerve. So basically they are from L1, and they get some contribution from T12 also. So that is prefix plexus, and they get some contribution from L2. Then when L1 and L2 join, they form which nerve? Genitofemoral nerve, right? Then posterior divisions of L2, L3, and L4 form the femoral nerve, and anterior divisions will form obturator nerve. So
Sir, may
these
I
are the
interrupt for a second? We are
yeah.
seeing actually volume of drug slide. Is it same
Okay.
with others?
No. Okay. Let me share it again.
Yes,
Okay.
sir, please.
I'm not able to see the actual
Okay.
slide.
Okay. Let me share it again. Now, can you see the slide?
Yes, sir.
Yeah.
Yes.
Sorry. So here you can see this is L1 root, this is L2, L3, and L4. So they form the lumbar plexus, and these are the branches of the L1 root. They are iliohypogastric nerve, which is at the top, and below is the ilioinguinal nerve. If we go below, L1 and L2 combine to form the genitofemoral nerve. Then L2, L3, L4 posterior divisions form the femoral nerve, while anterior divisions will make the obturator nerve. So if we look at the schematic diagram, L1, L2, L3, L4 forms the lumbar plexus, T12 gives some contribution in prefix plexus, and L5 give in some postfix plexus. So if we look at these branches, you can see this is the ilioinguinal nerve. Then you can see this is the iliohypogastric nerve. Then L1 and L2 combine to form genitofemoral nerve. Then L2, L3 form the LFCL. L2, L3, L4 combination posterior divisions form femoral nerve, while anterior divisions form the obturator nerve. At the same time, sometimes you will find accessory obturator nerve at least in the 20 to 30% of the patient, and it is formed by L3 and L4. And L5 and L4 combine to give lumbosacral trunk. So they give contribution to the sacral plexus. And this is also important video for anatomy. Here you can see this is psoas muscle. This is the psoas major and this is psoas minor muscle, and you can see genital femoral nerve lying over the psoas muscle, while femoral nerve and the lateral cutaneous nerve of thigh, they lie lateral to the psoas muscle, while obturator nerve lie in the separate compartment. And that is why with CP or infrainguinal femoral, infrainguinal approach, when we give higher volume, even if we give very high volume, obturator nerve is missed. Here again, this is the diagram which shows that these are the femoral and the lateral cutaneous nerve of thigh, and obturator nerve is lying in the separate compartment only. So with posterior approach only, you can block the obturator nerve. If we look at the landmark, I'll skip these slides. These are some anatomical variations. So this should be also covered in this thing, your anatomic presentation especially, but I'll skip it. So when we are talking of Vinny's approach, you have to draw a line through the spinous processes of L2, L3 and L4 spinous processes. So it is in the midline. You have to draw a line parallel to it, not 4 centimeter lateral. It is different approach. You have to draw a line through the posterior superior spine. Then you draw the Taphias line at the highest point of iliac crest. You join it, and this is your needle insertion point. But important point is you have to hit the transverse process. Then you have to walk off the transverse process. You should go cranially because you are at L4 level. So if you go cranially, you are for lumbar plexus only. If you go caudally, sometimes drug spread to the sacral plexus also. And then if you want to give sacral plexus block, you will not get desired response because of the drug spread. So this is landmark for Vinny's approach. But sometimes transverse process is completely missed with Vinny's approach, and that's why came the Capdevilas approach. And landmarks again same midline, line parallel to it through the posterior superior spine, and this is Taphias line. And then we have to divide into medial 2/3 and the lateral 1/3. And this is the needle entry point where we insert the needle, hit the transverse process, and walk up the transverse process to get the desired response. But the important point is from transverse process to plexus distance is 2 centimeter. Basically, plexus lies in the there is a compartment at the junction of anterior 2/3 and posterior 1/3 of the psoas muscle. So anterior is a bulky muscle part, and posteriorly there will be a smaller part, and in between there lies the components of the lumbar plexus. So these are another approach, that is Chen's approach, that is Decre's approach. So these are various approaches. So you have to describe all these approaches properly. Again, you can see this video to see how the contraction appear. This is Capdevilas approach. I'm inserting the needle, I'm hitting the transverse process, and then I am redirecting it little bit cranially to find the proper response. You can see I've gone 2 centimeter. I've kept my finger at 2 centimeter level so that I don't advance the needle too much. So you can see the contraction here, and that's where you inject the drug at 0.4 milliamps. But be careful. You should not go below 0.4 milliamps, because if you inject the drug below 0.4 milliamps, there are chances that drug will spread in the epidural space, or sometimes it will cause especially in Capdevilas approach, it can cause epidural spread, and there will be bilateral blocks. So selection of needle, it is common 100 to 150 in obese patient. This is important slide. So when you hit this, suppose patient is obese, this distance from skin to the transverse process, it may be different. It may vary from 4 to 8 centimeter. In thinner patient, it is 4 to 5 centimeter, while in obese patient, sometimes it go up to 8 to 10 centimeter. But from the distance from the transverse process to the plexus is fixed, that is 1.8 to 2 centimeter. So you should not go beyond 2 centimeter. Otherwise you will injure important structures inside the abdomen, like kidney or other visceral structure. So you have to be very careful. Another important point is don't attach into the needle while locating the plexus or extension tubing, because sometimes if you accidentally puncture vessel, there are lumbar vessels very close to the plexus, so you can easily puncture that. there will be free flow of the blood through the syringe, needle or the extension tubing if you have not attached the syringe to the needle. Otherwise, you will miss it. And sometimes if you go too medially, you can puncture the dura and it can cause subarachnoid puncture. And if you inject drug there, it will lead to total spinal. And there are reports of total spinal in literature. So you have to be very careful while giving this block. This is a level 3 block or advanced block. So keep these things in your mind. Another important point, this slide is explained very nicely by PAVAN. Ultrasound approach he has described very nicely. So I'll skip those slide, but this is important. As I said, lumbar, these are the lumbar vessels. They lie very close to the plexus, so you can easily puncture those, and that is why it is contraindication indicated in the patient with antiplatelet and anticoagulant. It can easily cause psoas hematoma if patient is on anticoagulant or antiplatelet drugs. So you should avoid it. I'll show in video also. Here you can see. This is the video. You can see. You can see these are the lumbar vessels lying very close to the plexus. So you have to be careful. And this is the ultrasound image. You can see this is the thumbs up appearance, and you can see vessel lying very close to the plexus in the substance of the psoas muscle. So you have to be very careful while giving this block. You have to aspirate properly. You should keep talking to the patient, or you should monitor the patient for the last. So these are important point I wanted to tell all of you. And this is also important that kidney is also lying very close to the plexus, especially at L3 level. So if you are using a Derkis approach, then you have to be careful about kidney injury also. So these are the pulse. You have to keep these things in mind. I think TVS sir also explained all these things very nicely, but I'm repeating for those who have forgotten it. Any other point, if anyone want to discuss? Ankit is there. Ankit, Dr. Ankit.
I think you have covered most of the points, sir. So mainly it is a deep block, and the arteries lie very close to it. So also when you are doing an ultrasound guided block, you have to avoid going too medial. If you go too medial in search of the nerve, then you are likely to hit the dorsal artery or the lumbar arteries over there, and that can cause arterial injections. And secondly, for adult patients, especially if there is any issue regarding coagulation, you have to remember that this is a deep block and it should be avoided. So all the guidelines which are there for deep blocks, you have to follow them.
Yeah, that is very important. You have to follow the guidelines for the deep block. You should not give even sacral plexus. Inferior gluteal artery is lying very close to the sacral plexus, so you have to be very careful while giving these two blocks. These are, as I said, advanced level block, and chances of local anesthetic systemic toxicity are high. Anything else anyone wants to add or anyone wants to ask?
Sir, Dr. Kapil, yeah, good evening, sir.
Yeah, good evening.
Sir, I had a doubt. You mentioned that there's a high propensity to go epidural or intrathecal as a complication, right?
Yeah.
So, sir, while aspirating, is it any different how it would look? Because we specifically look for blood while aspiration.
Yeah.
And if it happens to be CSF and if we are giving it by a 10 ml syringe, it wouldn't be as clear as we observe the aspiration while giving a spinal, right? Because during spinal, it's a smaller syringe. This is a bigger syringe.
Yeah, it is same. But sometimes it is as the color of CSF is similar to, drug. It is clear. So sometimes there are chances if you miss it. So if you keep the needle end or extension tubing end open to the atmosphere, then there are less chances of missing it. There will be backflow of the CSF or blood through the needle hub, and you will find it easily. So this is the block where I will keep the needle end open to the air, and the another block, that is thoracic paravertebral block, where I keep the needle end close. I always attach to syringe to the needle or extension tubing. Why? Because here we are worried about pneumothorax. So if it is open to the air, With respiration, it will suck the air and it will create a pneumothorax.
Yes,
But with thoracic paravertebral block, if you attach the syringe to the needle, even if you puncture the pleura, it won't suck air inside, and there are less chances of pneumothorax if
yes.
you attach
It
syringe to the.
creates kind of a seal.
Yeah. So you have to remember this thing, this two important point while giving thoracic paravertebral block and lumbar plexus block. When you give thoracic paravertebral block, always attach syringe, but when you give lumbar plexus block, always keep needle and open to the atmosphere.
Yes, sir. Thank you, sir. Understood.
Yeah. And another important point, never advance needle medially. If you go medially, then because this is a deep block, even angulation of 5 or 10 degree will lead you to towards the midline. As you have seen while giving paramedian approach spinal, we
Yes, sir.
keep
Yes, sir.
the needle 2 to 3 centimeter lateral to the midline, and we insert the needle with angle. So with same technique, even if you are 4 centimeters, sometimes you will reach the subarachnoid space, especially in obese patients. So you have to be careful.
Yes, sir. Yes, sir. Noted.
Any other questions or any other comments, Senthil?
Good evening, sir.
Yeah.
Sir, how will we identify if we are in the epidural space for this block?
Actually, there is a dural cuff or sheath even when now comes out of the mid spinal cord. So sometimes when you inject the drug and if you are finding resistance, like more if your injection pressure monitor, if it is going more than 15 or 20, or if you are getting response at 0.4 milliamps or lower, then there are chances that drug will spread in the epidural bed, even if you are not in the epidural space through the dural sieve. So when you are injecting the drug, you have to check the resistance. You have to inject the slowly. So if you inject fast and against resistance, then there are chances that drug will spread in the epidural space. But we are not much worried about epidural spread because even with 20 ml of LA, you will not have like too high level of the block and too much of hypotension. Yeah, of course, it is more than unilateral lumbar plexus block, but you can easily manage it. But if it is in subarachnoid space, then it is a real problem. It will be total spinal, and there are reports of cardiac arrest and death with lumbar plexus block.
Okay.
Good evening, sir. Hello, sir.
Hello. Yeah, you can ask.
Sir, in dual guidance block, there for PNS also we have to keep the current at starting with the 1, or we can directly keep it at the 0.4 and then we can advance.
Actually,
with
ultrasound, it is difficult to identify exact flexure. So I'll keep the PNS at 1 milliamps rather than going to 0.5 milliamps directly, as we are doing in other blocks like interscalene block or femoral block. So in this block especially, I will keep the PNS at 1 milliamp in the dual guidance. I don't go directly to 0.5 milliamps.
Okay, sir.
Good evening, sir. Dr. Millennia. If I may add one point.
Yeah, please.
Yeah. So in the while performing a lumbar plexus block with the help of USG, the psoas muscle has many intramuscular tendons, which also look hyperechoic and can be confused with the lumbar plexus. So while performing the lumbar plexus block, it's important to use the PNS and get the desired quadricep response, because when you are around the intramuscular tendons, you might confuse it with the lumbar plexus, and you might deposit the drug there, and you'll get no response. So that's how we will confirm that it's the intramuscular tendon and not the lumbar plexus. So it's important to remember that there are intramuscular tendons within the psoas muscle which can be confused with the lumbar plexus.
Yeah, absolutely. Milind, you're absolutely right. Actually, this is one of the blocks where it has been proven that dual guidance is better than ultrasound. So you have to use dual guidance. It's always preferable to use dual guidance because of the same reason. It's a deep block, and secondly, there are lots of intramuscular tendons within the psoas muscle. which can be confused with the nerve. So to be absolutely sure, it is always better to use dual guidance.
Hello. Hello.
Yes, Senthil sir, please tell.
Just wanted to pass a comment. And the lumbar plexus, lumbar sacral plexus blocks are reserved only for high risk cases nowadays. It's not a routine block, and it is used, I think, only for giving anesthesia. It's not an analgesic block. And many a times the high risk patients are elderly patients, so there is no echo contrast as well. So you will have to be careful in using a dual guidance, because there is no echo contrast and also intramuscular tendons. So you need always a dual guidance to do the lumbar plexus block. And many a times when you place in the shamrock method, when you approach, you might have to approach in the interspinous view. You just have to tilt the probe and then bring in the articular process and then do the block. So directly shamrock method, where the spinous process of L4 is visible, you might hit the L4 vertebra, the spinous process. So for that, you'll have to tilt the probe so that you are in the interspinous area, and then you can do the block.
Right, sir.
Yeah, that's true, Senthil.
I have a question for the fellows, especially Pavan and Kishore. How will you confirm L4? We are talking about L4, L4. So how will you be sure that you are at L4? Especially for USG guided.
Ma'am, we will we will draw Tophius line. We will palpate the posterior superiliac spine. The Tophius line goes from the L4 and L5 vertebra, and also with the help of USG guided, we can scan the transverse process, spinous process from L5 upwards, sacrum.
Yeah, ultrasound is the right answer, but with
Yes.
Tophius line, there is a study with Tophius line. You get only in 20-30% of the patient you are at the right place. You will go either at the higher level or at the lower level with Tophius line. Mostly at the higher level, because in obese patient and in female short stature patient, you will definitely go at L1, L2, L2, L3 level, and you don't get any response with Tophius line. So it is important to use ultrasound to find the right level.
Okay.
Right, sir. And my another question is, if you look the discussion, we all agree that it's not a simple block, it's a deep block with many complications and many limitations. So where will you look for using this block as compared to having a simple spinal to this patient? Because if I compare, the contraindications are also similar for lumbar plexus block, lumbosacral plexus block and spinal. So my question is, where will you choose lumbosacral plexus block over spinal, which is a simple procedure which we are doing day in and day out?
Low cardiac output patients, cardiac. So to avoid which are patients to avoid GA, we can, for hip surgeries, we can perform this, ma'am, lumbosacral plexus.
Right.
And then
And what is the disadvantage of giving lumbosacral compared to spinal in such cases?
ma'am, it's a deep block, and it is in such patient the mark we can not able to get the marking right sometimes, and because of the, if there is hip surgery, we will not able to give the position directly, lateral decubitus position. So first we have to give the other blocks to get the lateral decubitus position, and sometimes the patient is not cannot give the sedation, as patient is not able to tolerate in such high risk patients. So sometimes that is difficulty to manage the patient in lumbosacral plexus block.
Right. And one more thing is, if it's spinal, you're blocking both sides and giving position for some surgeries, hip surgeries and all. The non-blocked leg in this kind of lumbosacral plexus block will be a challenge for us. These are frail old patients. So putting the load of the body on non-blocked leg will also be a challenge.
Even
So
on fracture table, it is difficult to
yeah.
give.
So not only it's a difficult block procedure wise and complication wise, even the thought process has to be matured enough ki you are just blocking one side and having similar complications to spinal. So it's not an easy block. So my target is that when we are in exam, we are in sometimes want to show off that we know lumbosacral plexus block and all. But given a chance, if your patient's history suggests that you can use spinal, you talk about spinal rather than talking about such difficult block.
Okay, correct.
Hello. Hello.
Yes, sir.
Yes, sir. Please tell.
There is a difference between the volume of the drug that we give also. Spinal is only hardly 4 ml, 3 ml, 2 ml. So, but here this is a high volume block because you're giving two blocks, a lumbar plexus and sacral plexus. So you're using a high volume, and that is also another difference. And many a times, if I think Hetal sir will agree, many a times you might not get the twitches as well. You are near the
that's true.
plexus, but then sometimes you might not get the twitches. So we have to just go ahead with the ultrasound picture and then give the block as well. That is another thing. And most importantly, like any other infrainguinal, suprainguinal, facial plane blocks, even lumbar plexus block also consistently blocks lateral femoral gluteus nerve and your femoral nerve, but obturator nerve is spared sometimes in percentage, and ilioinguinal and ilioepigastric nerve is only covered in 10% of the cases.
And another thing is with the invention of continuous spinal anesthesia, which is now continuous spinal sets are easily available. So you can easily manage these cases with continuous spinal and isobaric drugs with similar hypotension and with less hemodynamic changes.
True, sir.
And regarding the hemodynamics, I feel only if the epidural space or the spinal space is approached while giving the lumbar plexus block, then the hemodynamics might get affected as in the spinal. But if you compare the hemodynamics, lumbosacral plexus will give you a better hemodynamics than your spinal.
Yeah, that is always there. But if you compare regular spinal with continuous spinal with isobaric drug, hemodynamic changes are less. Of course, more than lumbar plexus block, but it is comparatively less to the regular spinal with hyperbaric drug.
Okay, sir.
Okay, so I think we can go for quiz.
Okay, sir.
Any other questions from fellows? I think we are done.
No, I have one question.
Yeah, please.
Sir, can we approach the lumbar plexus through that transverse approach, sir? The trident sign approach.
Yeah,
The trident
I have tried it once or twice. We can do it, but it is difficult to visualize the needle. So it is more or less like out of plane approach or blind approach. You hit the transverse process and advance needle, and you can go through it. I have done 2-3 times.
Okay, sir.
Any more questions, fellows? Any queries?
So, Sangamitra, can I take leave?
Okay, sir. Okay.
You can go ahead with the quiz.
Yes, sir. Thank you. Thank you so much
Thank
for
you, sir.
joining, sir.
Thank you.
Is the screen visible?
Yes, ma'am.
Kindly scan and join, please. Anyone else is joining? Okay, Kapil, you are very fast. Thank you for joining. Anyone else is joining or shall I start? Okay. So Vinny described anterior approach for lumbar plexus block. In 2002, modified approach for more medial needle insertion was given by That's right, it was given by Shayan. Next, let's see. Oh, so Rutuja is stopping. Which of the following movement is preserved following posterior approach to lumbosacral plexus block? So plantar flexion of the foot. That's the correct answer. A bit of confusion here. Okay, Rutuja is still topping. Endpoint for lumbar plexus block is yes, all of are here correct. Quadriceps femoris. So Rutuja is still leading. While performing lumbar plexus block, injection pressure is more than 20 psi. Patient is unable to move both legs post block. Most likely complication is. This one is an easy one. Yes, we have discussed in length, so we all got the right answer. Oh, Rutuja is stopping. Which of the following is not described as complication of LPB? A bit tricky. I am talking only about lumbar plexus block. Yes, foot drop, that is part of sacral. So now Hash has taken the lead. In USG guided LP block, shamrock consists of yes, all of you got it right. I think the quiz is very simple this time. Rutuja is again leading. So we'll go to next question. Anterior approach to sciatic nerve was given by. One more. Yes, it was given by George P. Beck. So hash is again leading. Ant is back. I don't know which ant. Muscular branches are given to hip, knee, and ankle by. This is again a tricky question. Think about it. Wow, perfectly correct. It is because even though the tibial nerve doesn't provide any direct articular or muscular branch to the hip, but the extension muscles are given supply by tibial nerve, which helps to extend the leg at the hip joint. So ant is stopping again. Next question. Where are the roots of LP located at the level of L3, L4? I think again a simple one. Yes, this time I have made a very simple quiz. So again ant is leading. Which of the following is true about lumbar plexus block? Yes, you all got it right except one. That's okay. So hash is leading now. We are going for the next question. Which of the following is located lateral to the psoas major muscle? I think sir gave us a nice pictures, USG guided pictures. Yes, it is quadratus lumborum block. A bit confusion with transverse process, huh? Let's look at the scoreboard. Ant is leading. Next. Which of the following is not included in the lumbar plexus? Very simple. Yes. So ant is still leading, followed by hash. Comes my favorite one. An ESG guided LP block transfers oblique view from left side. Structure seen deep to psoas and adjacent to vertebral body is. Specifically on left side, huh? Subabdominal aorta actually. Let's see. Yeah, the game has changed. Now Ant and Kapil are leading. Of the 4 P's of testing lower extremity blockade, push, pull, punch, punt. Push stands for blockade of which one? It is actually push, pull, punch, punt. Sorry for the mistake. This is specifically given in Bala Venkat sir's Ganga's handbook. So if anyone has gone through that, will get the answer. Okay, we are almost there. So now Kapil is leading. Same simple one. Sartorius muscle is supplied by. सर गुड इवनिंग. क्विज सुरू आहे सर. हो हो एक सेकंड. हाँ. So Kapil is leading. Now we will go to next question. Posterior approach of the lumbar plexus block, named the psoas compartment block, was described by. Bit challenging. We need to study a bit more. No answer, so scoreboard remains the same. L1 nerve root with T12 splits into an upper and lower branch. The lower branch forms which nerve with L2? Sir has explained it in very much detail. Genitofemoral. That's the right answer. Let's see. Yeah, Ant is coming back and Kapil is still leading, then followed by Tejas. The ventral branches of L2, L3 and L4 form the dash nerve. Focus on the word. I'm talking about ventral branches. Yes, you got it right. Sir has described it. So is Pavan. It is obturator. Let's see. Oh, Tejas is leading now in the last questions. Oh, last two. Only nerve in lumbar plexus which has no motor innervation. Very simple. Yes, Salefsian. I think I have made the quiz very simple this time. Tejas is leading. Let's see at the last question. Image below describes which approach to lumbar plexus block. Look at the yellow marking. Somebody is thinking deep. Yes. Let's see who is the winner this time. So, winner is Tejas. Okay. So, today's winner is Tejas. And congratulations to Tejas. And we will close the session here. And see you all guys. And I'm very happy with the presentation. This time kids have done a lot of hard work. Especially when kids called and told me that they want to do extra. The class was only about discussion of the anatomy and sonoanatomy. But Pavan and Kishore has taken the initiative to present the blocks also. So that is well appreciated by all the faculties also. So thank you so much for joining. And let's meet again on 30th with Shivasa's masterclass. Thank you all of you.
Thank you, ma'am.
Thank you very much, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am.